this morning. So this is, in case you're in the wrong room, the Creating Trans-Inclusive Reproductive Healthcare Services kind of interactive workshop. And because it's got a kind of interactive component, if you find yourself sitting at a table alone, you might want to join a table that's got some other folks at it. You can be in a large group, as the center table is, or you can be in groups of 2s or 3s. I should have enough printouts for everybody, so just kind of cozy up to your name. My clicker is working. So I want to start off just by reiterating that beautiful acknowledgement from this morning, recognizing that we're gathered on the traditional ancestral stolen lands and also beautiful nations that were to Indigenous peoples. I make this acknowledgement to name my relationship to land into this space. So I'm a white settler and I'm a descendant of colonizers. I actually know the names and dates of when my ancestors arrived here, and I consider that an incredible privilege that I take very seriously. I also make this acknowledgement because we're going to be talking about trans inclusion today, we're going to be talking about sex and gender, and as we were beautifully introduced to this morning, the way that we understand these concepts is caught up in the colonial project. So before white settlers arrived here, there were hundreds and hundreds of ways of knowing and being gendered that belonged to the Indigenous peoples of this land, and part of the colonial project was an attempt at erasing all of those. So I'm going to be using language of colonizers today. I'm speaking English, and I'm going to be defining and describing terms in ways that are kind of part of and caught up in that colonial project. So just an acknowledgement of that. My clicker is not going to like me. I can press it 6 times and hope that it does something. Some folks here vote.
Anything? We're just going to remain it.
Maybe I'll just like smash it.
Give it a good hard push.
All right, perfect. I'm used to them being so sensitive that if you like look at it funny, it decides to change the slide. So the goal for this session, and we'll kind of cut it a little bit shorter than I have it outlined here, just in the interest of an ample lunchtime. I'm going to tell you who I am. I'm then going to identify the problem, why it is that trans-inclusive that thinking about trans inclusion prompts a kind of reconsideration of gendered space and the way that we currently design healthcare. And then the bulk of this presentation will be 4 problem-based scenarios where in your small groups, I'm going to introduce you to 4 fake people that I've put in a fake circumstance where things go wrong. And I've given you some discussion questions so that you can reflect on those scenarios, what we could do better, those types of things. Before I get started, I just do want to let you all know that we actually have a counselor in the room with us today. Mumtaz is in the corner. Give us a wave, Mumtaz. And so if at any point you are in need of some debriefing or someone to check in with, or otherwise just a friendly face, they are here for that purpose. And then we'll wrap up with some final questions at the end. So that's the plan for today. So who am I? My name is Lowik. I'm a non-binary trans person. I use they, them, their pronouns. I'm also a PhD candidate at the University of British Columbia, and my dissertation is interested in trans people's reproductive decision-making processes. So how it is that trans people make reproductive choices in life and all of the factors that impinge on or impact or facilitate those choices. And my dissertation builds on my master's, which was interested in trans-inclusive abortion services specifically. And so I've been spending the last decade training abortion service providers on how it is to be trans-inclusive. I'm also a graduate academic assistant at the I work under Dr. Rod Knight, and our team is interested in all facets of substance use care for gender and sexual minorities. I'm currently editing a book, which I'm very excited about. All the chapters are slowly making their way to me about reproduction and parenting beyond the binary, so adding non-binary voices to the literature on parenting and reproduction narratives. And then I do all kinds of freelance trans-inclusive consulting. So I audit policies and practices, I conduct training sessions with everyone from OBGYNs to yoga studios. You name it, if you're interested in trans inclusion, I will come teach you how it's done. I'm also a cat parent. That is my cat interrupting my many hat photo shoot. So I'm a good queer, I like cats. All right, so identifying the problem. Some of this terminology is going to be new to you. Some of it will be old hat. That is perfectly okay.
I invite you all to think about sex as a medical and legal assignment that's made to the body of in utero fetuses and neonates, typically based on the appearance of the genitals. So most of us know our sex because we know what our genitals look like. And of course, sex is biophysical and has all of these kind of other components that make up our human bodies. But as we are delving into sex and gender-based analysis in our research and in our clinical care, we're starting to realize more and more that this category of sex, dividing people up based on their genital assignments, is actually not all that fruitful, and that there's oftentimes very many similarities among people of so-called different sexes. And so this becomes this medical and legal category that follows you around, oftentimes on identity documents, that kind of thing. Typically, the assignments available are male and female, but of course we need to acknowledge that intersex people exist and that we do horrible things to intersex infants in the name of upholding this binary of sex categories. And then gender becomes all of the sociocultural meaning that we paint on top of those sexed bodies. So this changes across culture, across time, and across place. But for the most part, when we're talking about gender, we're talking about all of the norms, expectations, stereotypes, roles that we ascribe to or paint on top of these sexed bodies. I read an interesting study recently that demonstrated that we actually lower the frequency of our voice when we're talking to neonates and toddlers that we assume to be male. And so although there's something true about the fact that men have deeper voices, we're actually socializing that into our children by replicating a lower frequency in the way that we talk. So kind of fun, complicated relationship between sex and gender there. Most people are ascribed binary genders. Boy becomes man, girl becomes woman, but there are more and more people who are raising their children or attempting to raise their children in gender-neutral ways. So we're seeing a kind of shift here. But nevertheless, gender is, we describe it as this kind of internal felt sense of self. And that doesn't necessarily have to align with the sociocultural norms associated about how we ought to relate to our bodies. So cisgender then, again, may be a term that you're familiar with, is an adjective that we use to describe anyone whose sex assignment at birth and current gender identity align based on those sociocultural values. So if you were born and assigned male because of the presence of a penis and you identify at this moment as a man, we would say that you're a cisgender man. And that's just a descriptive adjective to describe the kind of man that you are. And then, of course, transgender is this beautiful umbrella term that we use to describe all of the hundreds of different ways of identifying differently than that. Of course, the issue with any umbrella term is that it has a tendency to obscure the differences among peoples. And so just like there are hundreds of different ways of being a woman, and some people stretch that category of woman to fit it over their heads, so too with trans, there are hundreds of different ways of being trans. But for the most part, this is an umbrella that we use as a shorthand, as opposed to trans man, trans woman, non-binary, genderqueer, agender, gender neutral, et cetera, et cetera, et cetera. That becomes kind of very difficult to say in one breath. So we just say trans, and we recognize the problems with that umbrella language. And just a note here that as I provide you with this definition, recognizing that there are some people who will fit it, who were assigned one sex and identify differently now, who do not call themselves trans, who call themselves simply men or women, or who identify as non-binary and reject the very idea that cisgender and transgender is a binary. And it's much more complicated than that. But for the purposes of today's conversation, trans people are people who identify differently than the way that they were assigned at birth. I find the concept of cis-normativity actually much more productive than talking about trans people versus cis people, so taking it away from identity and recognizing that we've built systems and structures, institutions, the entire system of healthcare under the assumption and expectation that everybody is either male or female, which erases intersex people, and that everybody kind of ought to have their gender align with that sex assignment at birth. So again, as aforementioned earlier this morning, a part of this is a kind of legacy of colonization, that settlers came here and brought with them, for the most part, very Christian understandings of sex and gender, and we've built entire institutions around those categories. And it's this kind of system of cisnormativity that we're going to be challenging in today's workshop, something that I like to kind of, as an anarchist, burn to the ground as best as I possibly can. So the assumption in our societies is that all people will be cisgender, and transgender people then become the exception to the rule, the abnormality, the kind of difference that we need to somehow explain away or find a cause for, without recognizing that, of course, all of our genders are socially constructed, and all of our genders are either kind of bolstered by the institutions that we live within or tampered down by those institutions. And then the final definition, I'll stop flooding you with definitions, is transnormativity. And this is something that perhaps you are new to, in case everything that I've said so far, you're like, yeah, AJ, I got it. This is something that maybe you hadn't considered before. And this is that when we think about trans people, there are norms around who trans people are kind of perceived to be. One of those is that trans people are assumed to be binary. So the assumption is that there are trans men and there are trans women, and we don't often think about non-binary people. And then the second assumption is that trans people will access, or at least desire access, to medical transition so that their, quote, bodies match their minds. And what this does is use cisgender people as the measuring stick. And it says things like, well, if you're a woman doesn't have a penis, therefore you should desire to no longer have a penis. Or if you're a man, men don't get pregnant, therefore you should never desire to get pregnant. And so we use cisgender people and cisgender relationships to bodies as the measuring stick, and then we hold trans people up to those and determine whether they're, quote unquote, trans enough. And this is something that I explore a lot in my research on reproduction, because as I said, there's kind of reproductive norms and expectations caught up in this too. As I said, if you're a man, you ought not want to desire pregnancy, but men get pregnant all of the time and are still men. And so just recognizing that as much as there is cisnormativity, there's also transnormativity, and trans people are constantly being kind of measured against this measuring stick of whether they're trans enough, and reproductive narratives are caught up in that. Ultimately, what I'm interested in and what we're going to be tackling today is what I call the cisnormatively gendered silos of reproductive life and health, which is a mouthful. But for the most part, what we're describing here is men's health and women's health as unique and distinct silos. I typically am in the position of talking to women's health educators, so I'm often talking to OBGYNs or abortion clinic providers, folks who are working under the sphere of women's health, and I go in and I trouble that to no end. And so this is a lovely opportunity for me to talk to folks working under the silo of men's health, where, as we'll see in this session today, there are similar problems with siloing care under the kind of auspices of gender, where what I've noticed more and more is, for example, men's health spaces saying, well, we want to be inclusive of all men, and that includes trans men. Excellent, well done, they are men, they're welcome in men's spaces. But that's often done without recognizing that some trans men have vulvas, and that to actually serve trans men means recognizing that you're going to have to do things like pregnancy tests and pap smears, and things that we would commonly associate with women's health care. And conversely, if we have women's health spaces that are including trans women, absolutely, do it, trans women are women. They don't recognize that that means doing things like penile STBBI swabs or checking for prostate cancer, that it's actually about the body, and that if we simply hold up these silos and then expand them to include trans people, ultimately what we'll have is two silos who are performing the identical health care, but calling one men's and one women's. And again, the anarchist in me says, burn these beautiful silos to the ground. Thanks. And of course, the thing that is often missed here is non-binary people. Non-binary people exist, and we need healthcare. And I can tell you as a non-binary person myself that it is incredibly distressing to go into either a men's or a women's healthcare space and be told that I'm welcome despite the fact that the room is plastered with gendered smiling faces of people who do not look like me. And also recognizing that I have incredible privilege as a white trans person, that I can navigate these spaces comfortably, but there are, of course, folks of color who are not so fortunate, that these silos are also silos of racism and silos of colonization and silos of ableism, et cetera, et cetera. So that's the problem. That's the thing that we're going to be talking about for the rest of this session. The goal now is in your small groups, and if your group is a large one and you're finding it difficult to have a conversation, you can divide it up even further. If Jose is in the room, Jose is going to help me hand out some packets. We have English language, French language, and large print versions of all of these 4 scenarios. We're going to take 10 minutes with each one, so I'll let you know when 10 minutes is up and you're going to switch to the next scenario. And ultimately, each scenario introduces you to a fake person. This person is fake, but their experiences are based on real things that have actually happened. The places are also fake, so I haven't named any particular hospital or clinic, but you can maybe read between the lines there a little bit. And then following each scenario is a set of questions. And so I'll just get you for 10 minutes to read the scenario, reflect on it, answer those questions, and then when 10 minutes are up, I'll change the slide, I'll announce that we're moving on to the next one, and we'll do that for all 4. So that'll be about 40 minutes. And then after that, we'll come back and just chat about what we learned, what we found challenging, what we found enlightening, etc. So Jose is passing these around. Let us know if you need French or large print versions of either of these things. And recognize that although this is a gay men's health conference, because I like troubling the binary, not all of these fictional people are gay trans men. There's a lot of variety in those scenarios here. So the first person that you're going to meet, ignore the timing at the bottom of that slide, is Ravi. So when the papers come to you, I'll set the clock for the first 10 minutes and we'll all in our groups talk about Ravi and all come around and eavesdrop on what you're doing. Set timer 10 minutes. Thank you. I know you've probably just broached the surface. I've given you very complicated things, but we're moving on. So next up, scenario 2, introduce yourselves to Adi. And again, you've only just begun, and I disrupt the status quo. All right, so we're moving on to scenario 3. Scenario 3 is Michael. And last but not least, and I'm only going to give you 8 minutes because we're so crunched for time and everyone's hungry. So last but not least, introduce yourselves to Rowan. And then after Rowan, we'll come back together and we'll very quickly summarize and chat together. All right, everyone, I'm going to call you back to the front of the room. Yeah, absolutely. All right. All right. My lovely colleague has suggested that we all collectively take some deep breaths. So we're going to inhale through the nose and exhale slowly through the mouth. Just concentrate on the feeling of that breath in your chest. Maybe you feel a cold sensation in your nostrils or a warm sensation when you exhale. Thank you for going on that incredibly fast roller coaster ride with me. I intentionally packed these scenarios with so much that I knew you would never be able to get through it in 10 minutes. You're welcome. But my goal here is to demonstrate that trans inclusion is more than just names and pronouns. And oftentimes we have organizations who, in all of their well-meaning good intentions, say that they are trans inclusive and have not thought beyond names and pronouns. So the goal of this session is for us to recognize that trans people's reproductive lives and health prompt us to critically consider the ways that we tie sex, gender, reproduction, and even parenting together in cisnormative ways, and then deliver service under those umbrellas of kind of gendered silos of care. And that frequently gendered healthcare providers are incredibly ill-equipped to serve trans people. And trans people end up being either guinea pigs of, you're the first time I've ever seen anyone like you before, or educators, where the trans person comes to you with more knowledge than you have as a clinician, and you are expecting them to educate. And some folks are able to do that, are willing to do that, but expecting your trans clients to educate you creates an undue burden and barrier for those people to receive competent care. And so, of course, this is a systematic issue. It starts in med schools. It starts in how we design our clinical spaces. It's about training. It's about intake forms. It's about design and architecture. There's so many layers here. But my goal was to demonstrate to you just how multifaceted trans inclusion needs to be when it comes to reproductive health spaces, and recognizing that this extends way beyond reproduction, that this is about the gendered silos of care writ large. So if you work in a men's health space and that health space is saying that includes trans men, what does that mean? And what do you actually need to do in order to make the space actually inclusive to trans men? We have a whopping 5 minutes left. If anyone has any reflections, comments, challenges, you don't need to make them public. You can come chat with me at lunch. But if anyone just wants to share anything that they found particularly eye-opening or particularly challenging, I heard so many lovely exasperated sighs. That was the point. So open to any final questions, comments, queries, funny remarks, anything that you might have to say. Yes? Yes, so in my dissertation, I interviewed 14 folks. 2 of the 14 had various reproductive healthcare services denied on the basis of the gender marker on their ID. So the folks in my study were not abortion specific, but they were things like pap smears and hysterectomies. And so our schedule of billing, it's what it's called in this province, attaches a sex marker to a health service and then only allows people with that sex marker to have that service billed. So that is absolutely true and real, and this is becoming more and more a problem as folks are getting X markers because no system in the province is prepared for the X, even though they made the X an option, and even just between the M's and the F's. So this is absolutely true. Yes? Excellent. Yeah. Great question. So My suggestion is always to ask each and every client what words they use for their body parts. There's lots of trans women who will call their phallus a phallus, or they'll use the word clit dick. And so people are creating language for their body parts that maybe is not common or not commonly known, but it's in this practice of asking folks, recognizing that even some cisgender women don't like the word breasts for their chest. They use some other language. And so mimicking the language that your clients use, but also providing each and every client the opportunity to tell you what language that they use, recognizing that sometimes things like medical intake forms and informed consent documents have to use very particular kind of sterile scientific language, and acknowledging the limitations of that, but in those one-to-one interactions saying, okay, so we're going to be doing some birth control counseling now. What language do you use to refer to your body parts? And if you've got a partner, what language do they use to refer to theirs? And then doing your best, recognizing you're going to make mistakes, but doing your best to then use that language in those one-to-one interactions. So the same would be something like vulva. A lot of folks use the word front bum or front hole as an alternative to vulva, and recognizing that there'll be a little bit of a linguistic hurdle, but with some practice, those words roll off the tongue just as easily as the ones that we're more commonly used to saying. But yeah, ask and don't assume is the general guidance there. We have 2 more minutes. Yes?
So are things changing? How fast and slow are they?
Slowly, yeah. I'm working really hard, but I'm but one person. More and more, I'm finding that folks are invested in this conversation and they want to be trans inclusive, they just don't know how. And so they're getting to the point of renaming themselves or putting it in their mission statement kind of thing, but they're not actually thinking through the logistics of that, because it requires a particular expertise that you can't teach yourself. You need someone to come in and help. So a lot of movement in a lot of places, and also a lot of resistance in a lot of places. And some of the resistance that I encounter is in folks who have particular so-called feminist affiliations that don't allow them to see the forest through the trees, and they hold on to particular gendered ideology and think that trans inclusion is somehow going to dismantle their understanding of woman or of man. And what I always tell folks is that we're asking you to expand the frame, not throw the frame out altogether. And that the vast majority of your clients might still be cisgender, but for that one trans person that you've preemptively thought about and anticipated their arrival, that could be the difference between mental well-being and mental distress. And so, yeah, movement is happening. It's happening with individuals and within isolated institutions. It's happening at UBC Midwifery. They're doing really great work there and have created a very trans-inclusive midwifery program. I teach doulas, I teach abortion providers, OBGYNs, all kinds of different folks. So the folks who are invested in the conversation are knocking down at my door. The trouble is the folks who don't want the education, you can't get in the room. So that's always fun. It's like, I need you most to come. And they're like, no, I'm not coming. And that is us for time. Thank you so much, everyone, for coming. Enjoy your lunch. Seek me out if you have extra questions, comments. I know a few of you have said that you'd like to chat with me already. I am here for you. Have fun.